Good afternoon, everybody. It's our proud privilege to introduce Dr. Mauro Farella. He's a professor and chair of orthodontics, head of the postgraduate program in orthodontics, and director of research program craniofacial research at Faculty of Dentistry of University of Otago, New Zealand. He has been awarded certified membership in both European Board of Orthodontics and of the Australasian Orthodontic Board, reflecting his high standard of clinical excellence. His current main research interests include clinical orthodontics, biomechanics, craniofacial growth and imaging, jaw function, translational research using animal models, and development of wearable devices in dentistry and orthodontics. In addition, Mauro Farella is widely recognized expert in orofacial muscles, bruxism, and temporomandibular joint research. Internationally, his past research endeavors have been supported with research grants amounting to over 1 million euros.
No, there is some more. I am reading. He has published about 200 manuscripts, the vast majority of which are original research, with several appearing in top-ranked dental journals, such as Journal of Dental Research. He is Associate Editor of the Journal of Orthodontics and Craniofacial Research and Korean Journal of Orthodontics. He serves on the editorial boards of Journal of Oral Rehabilitation and of the European Journal of Oral Sciences. He has lectured in 22 different countries and is recipient of several national and international research prizes, such as Alan Docking Award from International Association of Dental Research and the Sir John Walsh Award and the Research Supervisor of the Year 2021 Award, to acknowledge the excellence received in dental research and postgraduate supervision. He has been appointed honorary professor at the University of Nanjing, China, and adjunct professor at the University of Cagliari, Italy. Dr. Farella is a specialist in orthodontics registered in New Zealand and Italy and holds a private practice focused exclusively on clinical orthodontics. With this, I welcome Dr. Farella, and the stage is yours. Please continue.
Thank you. Namaste. Namaste, everyone. Good afternoon, ladies and gentlemen, and a special thanks for your nice introduction and to the organizing committee to give me the opportunity to speak at this conference. This is the first time that I am in New Zealand, and I'm very honored to be here with you today. As it was told, I come from New Zealand, which is a long way, and more in particular from the deep south of New Zealand, the region of Otago. That's where I live, in the city of Dunedin, which is New Zealand's very popular for the beautiful scenery, and these are some of the beaches that are not far away from my house, and they have been used as a popular place for movies, also for Hollywood movies. There is the lake region of Queenstown or Lake Wanaka, and some beautiful region. This is the Fjordland. We have, this is my department of orthodontics, with colleagues and staff. There is only one dental school in New Zealand, and I have the privilege to lead the orthodontic department there. I am originally from Italy, though, and what you see here is Mount Vesuvio, and I proudly retain, as some of you may recognize, my Italian accent. I'm going to talk about class 2 malocclusion from childhood to adult. I choose this topic because they are the most frequent malocclusion that we can encounter in our clinical practice, and if we consider class 2-1 and class 2 malocclusion, their prevalence sum up to over 60% of the malocclusion. We know that it is important to make a diagnosis it's important to understand the position of a dentition relatively to the underlying skeletal bone, and that there can be different manifestations of class 2 malocclusion. And as orthodontists, we must be able to identify that. And there may be different criteria that can be used here. Some of my preferred lines for diagnosis and for identification of the position of incisor relatively to the underlying skeletal base. This is the outline of my presentation. I try to take some symbols from India here, like the peacock. And I'm going to talk about 4 age groups and try to give 8 evidence-based highlight and 12 case examples. So it's quite an ambitious outline. And these are the 4 ages, and I will start from early school children, so for patients that are under the age of 9. We know there are indications for early treatment in orthodontics that are well established, and they are listed here, but my focus is on class 2 malocclusion. When do we start treatment for class 2 malocclusion? Well, the literature is very clear here. If we look at the pyramid of evidence, there are systematic reviews. Actually, there is a Cochrane systematic reviews that has shown very clearly that providing orthodontic treatment for children under 9 years old is in patients with prominent upper teeth, that means class 2 malocclusion, is no more effective than providing a single course of treatment. Actually takes even more time. And this is a very robust evidence that we can't ignore. There are exceptions where I believe we should consider an early treatment for class 2 malocclusion, and in particular when there is a high risk of traumatic dental injuries and when our patients are under teasing and under bullying. And there is a good body of evidence here. It's not randomized controlled trials, but it's retrospective research showing that a large overjet is a risk factor for traumatic dental injury. It's not a big effect. If some of you are familiar with the NNT is 7, you mean you have to treat 7 cases to prevent 1 accident of traumatic dental injuries. So what do we do? How do we identify these patients? Personally, I believe it's very important during the consultation with patients to collect demographic information. We know that boys are at high risk of girls. We know that when there is no lip coverage, or the boys that are engaged in a very high activity level, for instance, in New Zealand, a lot of boys do rugby, which is also risk, and what I will call the risk-taking behavior. We also know that a large overjet, which is larger than 4 millimeters, is clearly associated with an increased risk of bullying. And this has been consistently shown in some research. So here, our responsibility as orthodontists to collect a comprehensive history with our patients, to engage with them, and to understand, to tailor our treatment to the specific patients. And if we delay treatment, the patients may be happy. So I think we do a good service to them. So this is my first evidence-based highlight that I really want to emphasize. Early treatment for class 2 malocclusion under age 9 is rarely indicated. However, a high risk of traumatic dental injuries, experiences of bullying may represent indication for an early treatment. Let's go ahead with ages. Now we have patients between 9 and 12 years old. And when we have patients between 9 and 12 years, the stage of dentition is largely variable. And you can find a patient like Elia that at age 10 has almost a full permanent dentition, or a patient like Moss that at age 12 is still in mixed dentition. We know from a landmark study by Jim McNamara that the majority of patients with a class 2 malocclusion have a smaller mandible. This is another well-established fact, whatever cephalometric analysis we do use. Over 60% of our patients have a smaller mandible. And this is definitely something that is provoking us to try a grow modification treatment. And you know that with grow modification, there are quite contrasting views, and these are examples of 3 opinion leaders that have completely different opinions about the effect of a grow modification. But there is a fact, and the facts are randomized controlled trials, and when we look at the results of randomized controlled trial, for instance, the effect of grow modification treatment on supplementary mandibular growth, we see that the effects are very small. We are talking about 1 or 2 millimeters of supplementary mandibular growth, which is probably of a questionable clinical relevance. So the second highlight is we know very well that grow modification appliance the effects are primarily dental alveolar, and there are a minimal effect on grow modification, which is of dubious clinical relevance. Another dilemma is about what is the right time to start the grow modification treatment. And that looks another controversial subject. This because there is some evidence, albeit I must stress that it's very weak, that if we do an orthodontic treatment, grow modification during the pubertal spurt, then the functional treatment will be more effective. But this evidence comes mostly from retrospective studies. And there is another challenge, how to identify the growth spurt. There has been an emphasis on the literature on different methods. The cervical stage is one of the most popular, but we have done some research, longitudinal research, looking at the occurrence of mandibular growth peak at different stage, and we found that the growth peak actually can occur in the first 4 stages. Cervical stage 1, 2, 3, 4. The only thing that we found that never occurs in stage 5 or 6. And our findings have been confirmed by other research and question the validity of the cervical stage to identify mandibular growth peak. Highlight number 3. There is currently no reliable or practical marker to identify the peak of mandibular growth. And what I personally do with the timing of growth modification, I start in late mixed dentition, which is more convenient and probably has less impact on treatment time, on orthodontic treatment time. This is a typical example. We have Vienna, she's 10 years old. She's a class 2 division, 2 malocclusion. She's in late mixed dentition, a few more primary teeth. And this is our VTO, the way we visualize treatment objective. We just want to procline a little bit the upper incisor. We can accept some dental alveolar effect and hopefully hoping a little bit of a grow modification is here. And this is what was done, a twin block, and then after the twin block, we have a posterior open bite, and then we want to extrude posterior teeth with a transition and function in a full fixed appliance, and that's the results that we can have with a combined grow modification and fixed appliance. I have a little bit of focus on twin block because it's most common functional appliance in Australia and in New Zealand. And I am now talking about innovation. I'm using more and more aligners, and I have the mandibular advancement system with aligners, and I have the big advantage that you can start moving teeth while advancing the mandible. Anyway, we are waiting more solid research in support of this system. This is an example of Eloise. She has a full unit class 2, a large overjet, has been treated with aligners, and in only 8 months there has been almost a full unit correction of the sagittal discrepancy. You can see that the results on grow modification is probably minimal here. But sometimes what we see with functional appliance is a remarkable response. Like in this case, this is a Summer. She's 10 years old. Again, she's in late mixed dentition, a large overjet, class 2 division 1 malocclusion. We want to retract a little bit the upper incisor, procline a bit to the lower, and hoping in a positive grow. And this is the twin block in place, and then this is the outcome. It's quite an impressive response, which may be tentative for us to think, but can we then grow mandibles? And many clinicians are astonished by these results. Myself, sometimes I found an impressive response to grow modification treatment. But then I want to show you another example, that is Diego. Diego is 12 years old, is an obvious convex profile, and this is occlusion. The overjet is not large, but he has a full unit class 2 occlusion, and this is Diego. I will show you directly at a 7-year follow-up. And this is Diego. She's 33 years old. And I generally question the audience and say, what do you think has been done here? Do you think, look at the facial convexity before and after. How do you think it's been treated? Class 2 elastics, orthodontic surgery, upper extraction with a camouflage, or with a functional appliance? And most of the people believe that it's been treated with a functional appliance, but actually he had a camouflage here with extraction of upper fours, as you can see in this image. And believe I did not use any elastics here. But the response to treatment has been excellent without any functional appliance. And you can see this into the superimposition on the cranial base. Look at the mandible before and after treatment, how much grow. And there has been a forward grow. So, and we know this very well from literature. This is from the Bolton study, the serial radiograph of a patient that has been untreated from age 8. Look at the overjet in particular, how progressively and spontaneously, without any treatment, the overjet has reduced, and there has been a reduction of facial convexity. And actually we know this since a long time. If you look at classical seminal work from Landy in the 50s, we know that there can be a differential maxillomandibular growth, which is very favorable for more mandibular growth in 1/3 of our patients. So what is my fourth highlight? A positive response to functional treatment, do not forget, they may simply result from favorable mandibular growth, which unfortunately nowadays is still unpredictable. But there is more and more a shift in orthodontics from teeth and to face, and to overall improvement of facial balance. And this is what we can do with orthodontics. This is a class 2 malocclusion with protrusive incisors, and he has been treated. This is the line that I use to assess the position of incisor. You see, the incisor should be here on this line. It's quite forward. There have been 4 extractions made in these patients, and look at what is the outcome after the treatment with 4 extraction. I would say this is an improvement in facial balance, an obvious improvement. But it's not always like that. Look at these patients. These patients has also protrusive incisor, but there are some gaps, and I think there was a questionable decision here about extracting 4 premolar. And what is the result of this treatment? It's a retrusive profile. So this patient, I think she looks 10 years older. So this is probably a questionable clinical outcome. But what do we know when we look at the evidence? Once again, we have a systematic reviews. There is a very well done systematic reviews from the Zurich team looking, for instance, at the effect of the position of the upper lip relatively to the rickets line. Meta-analyses are a little bit difficult to interpret, but I will make a summary. And the conclusion of this meta-analysis is that there has been, with upper extraction, a retraction of upper lip of 0.5 millimeter and 2.5 degrees of increase in nasolabial angle, which is considered clinically insignificant. But the problem of this meta-analysis, they pull all the data together, and we don't know how was anchorage management, how much crowding there was. And so really we have to be very careful interpreting this data. One more example, case number 7, another class 2 division 1 malocclusion with a very large overjet, nivet. Look at the position of incisor. It is still growing, and there is over 10 millimeter overjet here. We hope that growth will help, but the amount of overjet is quite large. So probably even under the best scenario of a favorable growth response, that will be insufficient to treat this case. And so a provocative treatment plan here, functional growth modification plus extraction of upper force. I have used in these patients a different appliance. This is called the bite jumping appliance. Has some advantage over the twin block, but is a little bit less well tolerated by the patients. We have done a randomized control trial on this appliance, and we have shown that there is a little bit bigger effect on growth modification than other appliance. And this is nivet before, then after transition and functional appliance, and this is the end result. A little bit of canine overcorrection here is almost in a slight class 3, which is good in these cases. This is the before and after, and this is a retention check at 7 months, where you can see a nice occlusal settling. The occlusion has settled very nicely here. And look at the change into the profile. Again, I think this is a big improvement. So orthodontic treatment may impact soft tissue profile. either positively or negatively. And this depends on our treatment plan and also what do we achieve in terms of incisor position. It's not just about extract or not extract. Our patients getting older, we are in the 13, 18 range, and there is a reduced growth potential, and there is a lower compliance and higher risk of procline the lower incisor too much, and anchorage management becomes more challenging. And we start to do a more careful planning. We need to think very well about anchorage management, to extraction pattern, to avoid round tripping, and when needed, to enhance the anchorage using a temporary skeletal anchorage as well. And this is a typical example. This is Isabella. She's 14 years old. She has a class 2 malocclusion, minimum lower crowding, but it's almost a full unit on the right-hand side and the edge-to-edge on the left-hand side. And she has butterfly incisor, and we want to leave the incisor where they are to maintain facial balance here. And this is a typical, a simple clinical pearl that I do very often. So I call partial engagement. If you engage the lateral incisor in this continuous arch wire with butterfly incisor, you just bring the incisor forward. And we want to bring the incisor backward because we have done extraction in this case. And we have also reinforced the anchorage using TEDs, meaning screw here in the posterior area. And this is the result, which is quite acceptable. I must tell you that I do quite often upper premolar extractions, and this decision is also a little bit backed up by retrospective research that's from a Brazilian group from Janssen, showing that generally the outcome for the management of class 2 malocclusion with the 2 upper extraction, with 4 extraction, tends to be a little bit better in terms of a canine relationship, overjet and overbite. But let's go ahead. That's another case example, my case number 9. This is Cameron, he is almost 16. And we have a class 2 division 2 malocclusion. We retrocline the upper incisor with almost a full unit class 2 occlusion to the right and an edge-to-edge to the left. And look at the profile. This is a retrusive profile. It's a sensitive profile. How do we manage these patients? What do we want to achieve? We want to procline a little bit the upper incisor, and we can accept a little bit of proclination of a lower incisor, but not too much. And how can we achieve that? This is another extraction pattern that I will define, an atypical extraction pattern that I do relatively often, which is upper second molar. The big advantage of extracting upper second molar compared to non-extraction is a less proclination of lower incisor. As you can see here, with class 2 elastic, we can expect almost 10 degrees of proclination on lower incisor. But when we extract the second molar, we have much less proclination, and we also have a little bit of a distalization, which in a critical anchorage case like Cameron can be very helpful. This has been done with a utility arch initially used for distal crown tipping here, and then extraction of upper 7 were made, and a forsus appliance, but we can use any fixed functional appliance at this stage, again, mostly with the dental velar effect. And you can see here, end of treatment. Well, a big question mark, about the wisdom teeth, but I have been lucky so far. I have many cases, and when I review long term, like in Cameron, you can see that the wisdom tooth comes very nicely here, and this is a very nice occlusion, and this is a follow-up 3 years after treatment. Case example number 10, Boniglia. Boniglia, again, is a class 2 division 2 malocclusion, quite a bit of crowding in the upper arch, but minimal crowding in the lower arch, a very sensitive profile, but look at the Ceph features. She has lower incisor extremely proclined. If we measure the IMPA angle, tweed angle, it's 115 degrees, which is a big red flag for using any class 2 elastics. In this case, we have used a different approach, which is skeletal anchorage, but this time we have used a distalizer from Benedict Wilms, a Bini slider. Actually, one of the screw has failed very early here, but it has worked very well despite the lack with only one screw. And these are the progressive stages of treatment. We have used a little bit the smart anchorage here to tuck the lateral incisor in, and this is the result after a couple of years of treatment for Boniglia. And we know there is systematic reviews with meta-analysis showing that we can distalize. Distalize is a feasible option, and the results of meta-analysis shows that on average 4 millimeters of distalization, which is definitely something that is clinically relevant and can help in our management of these patients. So my sixth highlight is that anchorage management plays a critical role in treating class 2 malocclusion in teenagers and can be effectively enhanced by the use of TEDs. We know that TEDs have expanded the spectrum of our possibility. Sometimes I believe there is also a bit of an overuse of TEDs because anchorage management means also making a smart choice and making the right treatment plan. We are going ahead with our patients, and now we go in the adulthood. And patients above 18 years old. What happens in patients that are above 18 years? There are new challenges, and the challenge is that there is no more growth potential. Well, there is a little bit of a late growth through the lifespan, but it's probably not helpful. We know that we can fix malocclusion, skeletal malocclusion with surgery, but at least in New Zealand, it's not easy to encourage patients to do surgery. It's not publicly funded, it costs a lot of money, and most of patients do not want surgery. And then there is periodontal issues that can increase with aging. Here, I want to say a few things about an overall emphasis that there is in the orthodontic world about what we call phase projection, chin projection, phase expansion is a concept that has been promoted by an American surgeon, Arnett, and one speaker before has mentioned the Hollywood smile. I will define this as the Hollywood profile of Angelina Jolie with a very pronounced chin. If we use Arnett reference here, we see that her lower chin is right in the ideal spot. But once again, I want to challenge this concept and say, is the retruded chin a concern for the patient or for the orthodontist? And we have done some, no, that's not our research. This is some research from a Brazilian group where there has been a stepwise advancement of the mandible, and lay people, as well as orthodontists, were encouraged to identify what is the threshold, how much mandibular advancement we can detect. Well, orthodontists could identify a stepwise advancement of 2 millimeters, but lay people could not identify a stepwise advancement of mandible of less than 4 millimeters. Less than 4 millimeters. And we have done also some other research in patients that underwent orthodontic surgery, all class 2, before and after treatment, and it's quite obvious that these patients has improved the position, but the patients, when we ask to lay people to score attractiveness of the patients before and after, the change was not as big as I expected. Contrary to orthodontists, that they tend to score the improvement in jaw position much more. What I want to say with this is that perhaps a slightly retrusive profile may also be acceptable, and sometimes it's also attractive. And I choose an Indian beauty here. I know there are others that should be popular, which has a relatively small chin. But as I told you, I come from Italy, and my colleague have done some research on Italian beauties. These are girls that have entered in a beauty competition. And what they have done, they have measured 2 cohorts of girls that entered in a beauty competition. They made many measurements, but I look at this measurement in particular, which is the size of the mandible relatively to the total face. And for 2 consecutive competitions, they found that the beauty girls, they have a little bit smaller mandible. And this has been found also in boys and girls that are engaged in TV commercials. So what I want to say that, once again, a little bit smaller mandible may be associated with enhanced facial attractiveness. We have some evidence, at least for girls, and we should consider this in our treatment plan as well. And Monique is a 23 years old girl. It's my case number 11. She is an obvious class 2, an overjet of 11 millimeter, very large, quite retrusive profile, nasolabial angle very obtuse. Actually, if you look at her, she doesn't want surgery, because if you look at occlusion and at the cephalometric features, she is an obvious surgical case. And look at the position of the lower incisor and the upper incisor and the very large overjet. There is a 110 tweed angle here. So what do we do when she doesn't want surgery? And a hard decision was made here to do camouflage treatment, once again, with upper force. A predicted retraction of the upper incisor of 8 millimeter and a bit of intrusion with the minimal proclination of lower incisor. I was really expecting a terrible outcome here when this decision was made. The anchorage was reinforced also with TEDs, and this is the outcome, which was surprisingly, I think this is a compromise result, but probably better than I expected. And so what happened here? I made a superimposition, and actually the incisor were retracted of 7 millimeter, and the nasolabial angle has changed minimally compared to the amount of retrusion. So the observed change were minor, and one question is why? It's because the lip was really not sensitive here to retrusion. Maybe it is ascribed to mechanical properties of the lip. And we're doing quite some exciting research, talking about innovation, the future. This is some of the research we do in Otago, measuring the viscoelastic properties of the lips. And we are looking at the same time at photogrammetry. This morning there has been some talk. We can make a very nice distance map measuring all the change in the position of lips. And at the same time, we use also artificial intelligence to track the landmark on the face. This is a long story. We have some publication here, but the results are encouraging because we found the mechanical properties of the lip can explain over 1/3 of the variability in lip response to incisor displacement. So this is something very exciting for the future. We are getting, our patients are getting older, and this is, we know that when patients are getting older, there is an increased risk of periodontal issues. Here we go, this is a graphic of a chart of the prevalence of periodontal issue by age group. And we know that orthodontics in aging patients becomes more challenging, because when there is a bone resorption, there is an apical migration of the center of resistance of tooth, and so we need a higher moment to force ratio, we need very low forces, and this is very difficult. And so in this case, as you can see, there is another class 2 division 1 malocclusion. This patient is older, she's over 40 years old, she's 44 actually, and you can see that in addition to the class 2 malocclusion, here there is a traumatic bite. Basically, a lower incisor fully impinge on the palatal mucosa. And this is where orthodontics becomes a lot more than aesthetics and becomes also function. And this is a challenge because you have a reduced periodontal support. And here, when you do the planning, we have to be very careful to how to correct this deep bite. And so ideally, we will need an intrusion, but also a little bit of an uprighting of the upper incisor and an intrusion mainly along the axis of the lower incisor. We don't want to procline the lower incisor. And this requires, again, some biomechanics consideration with low forces, high moment force ratio, and precise force direction. We know that when we engage all the teeth in a continuous arch wire, we have round tripping of the teeth with transitions between different Burston geometries, and that's not good for the periodontum, especially if the periodontal disease is not well controlled. So this is what we want to do, straightforward movement with an intrusion. And this is what has been done in these patients using Burston mechanics, intrusion, cantilever, a 3-piece of Burston with intrusion so that we can calibrate the force direction and get the correction that we want, intruding the upper incisor, but also uprighting the incisor at the same time. If we use Ted's mechanic with intrusion, we just flare out, in this case, the incisor. And so these are the different steps of the treatment, the progressive intrusion, and then finally a transition in a continuous arch wire, and the final outcome. And that's the correction of the deep bite before and after. That's my last highlight in periodontally compromised teeth. precise control of force, magnitude, and direction is crucial for treatment success. And we have done a nice review on this published in Periodontics in Perio 2000, which at the end of my lecture, I will give you all the references that I am quoting in my lecture today. So this comes a little bit to the conclusion of my talk. I have shown you class tumor occlusion management at different ages with 12 different cases. And what is obvious is that each case is different. We can't really standardize the way we treat class tumor occlusion because each case is unique and we need a personalized approach, which is probably the beauty of our job, to make each case unique. This is my reference list. Most of the references that I quoted can be downloaded through this optical code. So I will leave you a few seconds here. That seems that my talk is on time, and you will find all the references that I have quoted today. A very special thanks to my patients, my students that help me in the everyday clinic. These are the 12 new smiles that I have shown you today, some better than others. And I really gratefully acknowledge my team, my students, and my colleagues at the University of Otago that every day do this work with me. A big thank you, everyone, for your attention.
Thank you so much.
What is he saying?
I would request one of the chairperson.
There is no...
What is he saying?
You want this?
Just a minute, just a minute. That was an excellent presentation by Dr. Farella. If anyone in the audience has a question, no questions. Yeah. Okay. I request Dr. Farella to come over for the certificate. Yeah. Yeah. You want to say anything?
Now I would request one of the chairperson to kindly give the memento to Dr. Mauro.
Should I come here? Thank you. Thank you.
Now I request Dr. Rakesh Malhotra to kindly give the certificate of appreciation to chairpersons.
Very good afternoon. The speaker for the afternoon is Dr. Sumit Yadav. He's a professor and chair of Department of Growth and Development at UNMC College of Dentistry and Children's Hospital. He's Henry and Anne Seck Award endowed professor of orthodontics and board certified orthodontist. And he has published extensively and has more than 145 peer-reviewed articles. He has been funded through NIH and American Association of Orthodontic Foundation on orthodontic tooth movement and temporomandibular joint degeneration and regeneration. And he is also a director of Midwestern Society of Orthodontists and a member of Planning and Review Committee of American Association of Orthodontic Foundation. He is also an associate editor of Progress in Orthodontics and serves on the advisory council of Harvard Business Review. We welcome Sumit Yadav, and the stage is yours, Dr. Sumit.
Well, good afternoon, and greetings from UNMC Orthodontics. And at this point, I would like to thank Dr. Anup Baluri and all the team for giving me a chance to present my work. And today, just before that disclosure, I have no actual or potential conflict of interest in relation to this presentation. I do consult for Bay Materials. So today, I would like to cover 3 small topics. One is expansion, the other one is molar protraction, and the other one is class 3 correction. And if you would like to guess how many palatal expanders are used every year in patient's mouth, I'm going to give you a data from a single orthodontic company, which is more than 1 million. So just think about it. From one company, it's 1 million. From multi-companies, it would be multi-millions are going into the patient's mouth. But we are still not clear what's happening with the expansion. At this point of the time, I'm going to show you 2 different cases and then summarize the evidence which expansion method is the better one to do it in our patients. Let's look at a 16-year-old patient which came to my faculty practice, and class 3 dental, class 3 skeletal, constricted bite bilaterally, cross bite. And if you look at it, how will you expand? Either you will put jack screw, you will do tooth and tissue bond, you will do bone bond, or you will do arch wire. And just in this case, we tried, either you can say MSC, you can say MARPI, whatever you want to say. We tried 4 different screws to expand with 4 screws. And this is how in 1 week the patient looked like. This is a typical sign. The midline diastema came up. And at the same time, I started aligning the lower teeth. Again, we keep on expanding. This is 3 weeks. The midline diastema has increased. And at this point, we started closing the space and started preparing the patient for orthognathic surgery. And if you look at it, this is in preparation for the orthognathic surgery. And at this point, we started doing the surgical planning with the mimics. And what we planned in this patient was that we will operate the maxilla first and mandible will follow the path. And we did 2-piece maxilla between 8 and 9, and then 5 millimeters of advancement, 1.5 millimeters of global impaction, and then we corrected the cant, and mandible followed the path. And this is how patient looked like immediately after the surgery. And if you want to compare, this we are closing the space. This is how we started before, and this is how did the patient look like. And this is how we exactly finished the patient. And if you want to see how we expanded, you go from left to right. We started here, and then we finished it this way. Similarly, on the left side, we started here, and then we finished it this way. So in this patient, I showed you that you can use MARPI, MSC to correct the posterior crossbite and then finish it aesthetically. Now let's look at another case. This is an 18-year-old female, actually 20-year-old female, which came to my faculty practice, and she was a nursing student. And you can look at it. There is some anterior crowding and then bilateral posterior crossbite. Again, it's the same question. How will you expand? Either you can do jack screw, you can again do tooth and tissue bond, you can do bone bond, or you can do arch wire. So in this patient, 20 years old, we did the arch wire. And at this point of the time, patient got pregnant, so I have to remove the braces, and patient wanted the braces out. So I completely removed the braces. 7s were still in crossbite, so I let the patient wear cross elastics only in the night. And this is like 8 months into retention. You will see there is some posterior open bite. Patient had an Essex retainer, and she was wearing it very meticulously. So I asked the patient to reduce the time of the retainer wear. And this is 2 years down the road. Patient is tight, but patient was very happy, and the crossbite was corrected. So the question comes here is, which is better? An arch wire expansion, MARPE, or RME? And what appliance system should we use? We know that for sure, any appliance system you use, you would be able to expand the jaw and correct the crossbite. So where does the problem comes in? What happens with an expansion? There are two things happening with an expansion which could be detrimental to our patient. Number one is alveolar bone resorption. An alveolar bone resorption in the crest, which is a problematic because you cannot grow the vertical bone. And the second thing is the root resorption. Just look at it, why this is happening. Because if you look at it, the forces on the teeth, they are not physiological, right? A lot of FEM studies, including ours, have shown that there is some range of 10,000 gram to 20,000 gram of force on the molars and the premolars. So we have to be very careful in what we do to our patients. And I'll give you an example. Exactly what happens is, I'm not going to discuss in detail this animal study, but you look at it, control. As soon as you expand it, there's a huge loss in the bone. And when you allow it relapse, the vertical bones doesn't come back. And this is the same phenomenon which happens in the humans too. And the example is here. You expand it, it's in the crossbite, the molar tips like this, and you will lose the crestal bone height. And I'm a bone physiologist, and I know that I cannot regenerate the vertical bone loss. So what are we doing now? Are we creating the periodontal defect in a 12-year-old, a 16-year-old, or 20-year-old? We will do a 5-year-old follow-up, but after that, we don't follow up. It goes at 45, I don't know for what. So let's look at it. Let's look at the evidence behind it. So what we did was, this is our study. What we showed was, this is a long-term effects on alveolar bone with bone-anchored and tooth-anchored rapid palatal expansion. All the sample size in this study was done in Canada, Alberta, Canada. They were doing a randomized trial. And I asked my friend Manuel, can you give me the CBCTs? Because I want to look at the crestal bone height along with the other parameters. So he finished the study, and then he gave me all the CBCTs. So our 60 patients were divided into 3, bone-anchored, tooth-anchored, and control. And this is exactly how our bone-anchored device looked like. And this is exactly our tooth-anchored device looked like. And control was arch wire expansion. So if you look at it, T1 at the start of the treatment, T2 was taken after the expansion in bone-anchored and tooth-anchored, and 6 months after initial CBCT in the control. And T3 was at the end of the treatment. And this is our demographics, which were not different than each other. For the sake of the presentation, I'm going to only show you 2 parameters, which is the molar angulation and the vertical bone height. And if you look at it, focus your on the vertical bone height, and I'm going to take you through this journey, which is a little bit complex in this graph. So if you look at it, control T1 to control T2, and then control T3. Compare it. So if you look at it, control T1 is before the start of the treatment. Control T2 is 6 months after the treatment, and T3 is when the treatment is finished. So you don't see any bone loss or negligible bone loss with the arch wire. But if you look at it, bone anchored, T1 to T2 there is a significant bone loss. And if you look at it, T3, there is a bone loss. It's decreased, but it's still significant. But if you look at tooth anchored, the bone loss was much more compared to control, compared to bone anchored. So what we concluded, no difference in any treatment outcomes except the vertical bone loss, and molar angulation was significantly correlated with the vertical bone loss. And why this is happening? This is happening because if you just focus on this, the rectangle, if you look at it, the alveolar bone, right? When you're doing tooth anchored versus MARPI, how much of the stress is there, right? There's a difference, significant difference in the stress. And if you want to read much more, we have published this paper. So if you look at it, are we the first one to find out that this is happening? By the time I was doing my animal study, Ki-jeon Lee in South Korea was doing his human studies. And what he showed was very clear that the buccal tipping, which happens with an expansion of maxillary teeth upon MARPI, leads to decrease in buccal alveolar bone thickness and the crest height. And attending orthodontist should pay attention to these changes. So whenever you are expanding, be very careful. If you are going to put an RME alone, be very careful. Because I can tell you, you are creating a vertical bone defect. Do I have a long term? No, I don't. But I have a short term, or I have a little bit longer term than the other people. At least 3 years I have it, and it shows that the vertical bone does not come back in the animals, in the humans. So let's look at what happens with the root resorption. Because there are only two things detrimental with expansion. One is bone loss, and the second is root resorption. There is a fantastic article from our Turkish group, and they published in KJO. And what they did was, they expanded using these, they had 4 groups. It's a randomized trial, and they had one group with the TADs. The second group is tooth-based. The third group is acrylic covered, but tooth-based. So they said this as a hybrid. And the fourth one is completely acrylic covered. And the demographics are, they had 5 patients in each group, and the sample size was 10 because they extracted the premolars and they looked in the micro CT. And you know, like our CBCT can detect up to certain level, but micro CT has a 6 microns of resolution. They can find out every pit in the micro CT. So what they found out, this is very interesting. If you are using the mini implant based, there is almost negligible root resorption. But as soon as you use Hyrex acrylic bonded full coverage, the root resorption, whether on buccal, lingual, is significantly more without TADs. Now let's look at the root resorption number, because this gives you an accurate value. Again, with the hybrid, the root resorption was significantly less, or the number of lacunae, pits, they found out was significantly less at all the surfaces when compared to the other 3 groups. So if you look at it, what did they conclude? The amount of root resorption after RME was significantly less with mini implant supported hybrid appliance. The only limitations to this study was they measured the sample size was less. Secondly, like they were measuring in the premolar in the hybrid group where the force was applied on the molar. So like this is another drawback of the study. To overcome this drawback, like we also did the similar study. And ours is again the long term, because we know that there is some cellular cementum, there is acellular cementum. So even if you have a root resorption, some of the root resorption could be repaired. Again, our sample size is from Alberta, Canada. We had 65 patients. They did a randomized trial. And it's the same bone anchored, tooth anchored, and control. It's the same thing. Our methodology is exactly the same, except we measured the root resorption. And all the root resorptions were measured from the buccal cusp tip to the root apex. So if you look at it, what's happening with the molar length, control, that's an arch wire, we did not see any difference. RPE, just alone tooth anchored, we did saw any difference. MARPE, on the buccal root, we did not see any difference. Again, if you look at it, distal buccal root, the distal buccal root, whether it's an arch wire, whether it's an RPE, whether it's an MARPE, we saw that the root was resolved. And in the palatal root, it was the similar thing, similar findings. In the premolar, there was no resorption. So what we found out that within group, comparison showed that RPE leads to significant increase in root resorption. But when we compared all the three groups, we found out that there was no, one group was not different than the other group. So one thing is for sure, in the long term, the root resorption does not matter. Whether you are doing arch wire, whether you are doing MARME, MSC, MARPE, tooth anchored, root resorption does not matter. And just to confirm our findings, we did systematic review. We were not able to do meta-analysis because there was heterogeneous studies. So we did a systematic review. And this is a Prisma chart. In the end, we had 13 studies which analyzed the root resorption. And in all those 13 studies, there were 130 patients in tooth-borne, 88 patients in tooth and tissue-borne, 20 patients in bone-borne, and then there is some modified and hybrid appliances. And the females were 147, males were 116. And the age range was 7 to 16.3 years. And the conclusion of all the systematic review, of all the randomized trials were maxillary expansion with RPE leads to root resorption. Root resorption tends to be more on the buccal. And there is very limited evidence that MARPE prevents root resorption. There is some evidence, but limited. So that means we might have to do some more clinical trials, gather more sample size to say that MARPE can prevent the root resorption. So my take-home message, you can achieve expansion either with arch wire, Hyrex, HAS, MARPE, bone-borne. Root resorption, you have to be careful. You have to apply physiological forces. You can go with an arch wire, or you can do bone-borne, or you can do MARPE. And with the vertical bone loss, the only good thing is arch wire. If you are even doing MARPE, there is some. It's better than tooth-borne. But if you don't want any vertical bone loss or any vertical bone defects, you have to go with an arch wire expansion. The next thing I would like to target is molar protraction. And I'm targeting molar protraction because in my day-to-day practice, I see a lot of adult orthodontics and a lot of patients are requiring molar protraction. Or even in the kids, due to all the people migrating from South America, there's a lot of missing teeth due to caries and all, and I do treat young people in which I do a lot of molar protraction. So this is one of the studies, this is one of the area which I do study with my collaborators. So let's look at a 50-year-old guy which came to our residency clinic, and his chief complaint was obviously anterior crossbite, but there was missing molars. And if you look at the pan, there was minimal tipping of the molars, so that was a good thing. So what we started doing in this patient, we decided that we'll jump the bite, and at the same time, we'll protract the molar using the TADs. At that way, I can save the patient the cost of the implants. And you will see in next certain steps or next certain slides how we protracted the molar and using the TADs. And the patient at the end of the treatment was very happy. Though the occlusion was not perfect, we finished tight, but the main goal was to protract the molars, give him relieve him of anterior crossbite, and give him a definite occlusion. And if you look at it, the pan, just to see when we moved the molars, how did the molars look like? The molars did not tip. And there's a reason which I will cover later in my slides. Now let's look at another young patient which was treated by Dr. Chibber when he was a resident at UConn. And if you look at it, this has been published in AGO, you can read it. The patient had anterior crowding, and then the patient was missing 2 first molars due to caries. And again, what we did was we wanted to try something else in this patient to protract the molars. So we planned that we will extract the 2 upper premolars and treat that as a 4-by and finish it as class 1 malocclusion. So Dr. Chibber with his mentor, started uprighting the molars before he will start the protraction. And here, to protract the molars, he used the fixed functional appliance, which is a forceps in this case. And he protracted the molars using forceps, and he finished with a beautiful occlusion. So again, the question comes is, which is better? Either the TADs are better to protract the molars, or it's fixed functional appliance to protract the molars. And what evidence do we have for the protraction of the molars? So when you think about the molar protraction, there are 3 problematic things which happens. It's the type of the tooth movement, right? Most of the molar protraction, if you see, the crown will tip, right? That's the problem. The second thing is, if the crown will tip, tipping always causes loss of vertical bone. It's very similar to the expansion. You expand it like this, you lose the vertical bone. You tip it like this, you lose the vertical bone. And the third thing is the root resorption, because you would be moving 8 to 9 millimeters over an extended period of time. So thus, there is any root resorption. So our study, our group did this retrospective study which answered all the questions which I have posed till now. And the methodology was very simple, 12-year-old to start the treatment, unilateral or bilateral posterior edentulous spaces, absolute anchorage for lower molar protraction via TAD or fixed functional appliances. There were 36 patients in this study, 22 were female and 14 were male with 49 mandibular sites. Now let's see what was done in the TAD group and what was done in the fixed functional group. In the TAD group, protraction was done on 2125 or 1925 stainless steel arch wire. The TADs were placed between first and second premolar or first premolar and canine, and 300 centinewton of force was applied between the molar hook and the TAD. Whereas in the fixed functional appliance, protraction was done on a 2125 or 1925 stainless steel arch wire, and again, it was a 300 centinewton force applied from the canine hook to the molar hook. And these are the demographics in the fixed functional appliance versus the TAD group. And if you look at it, the protraction sites in the fixed functional appliance was 24, whereas in the TAD group was 25. The only difference was the mean age. In the TAD group, the patients were relatively younger. They were 15 years old, whereas in the TAD group, they were 20 years old. So let's look at our primary outcomes, which are very essential. If you look at the initial space for the molar protraction was close to 8 millimeters in the fixed functional. In the TAD, again, close to 8 millimeters. If you look at the protraction time, which was protraction time was 10 months in the fixed functional group, whereas close to 18 months in the TAD group. And we anticipate, protraction depends a lot on your bone, how your bone architecture is, but you have to keep in mind, our patients in the TAD group were older. They were 20 years old compared to 14 years old in the fixed functional group. So that might have been another reason why the protraction took longer time in the TAD group. And then again, if the protraction takes longer, the treatment time was longer in the TAD group compared to the fixed functional group. And there was no loss of anchorage either with the fixed functional or the protraction with the TADs. The best part was the secondary outcomes, which I was very interested in because I wanted to see whether your tooth is tipping or not. If you look at it, in the fixed functional group, there was no loss of bone. In the TAD group, there was some loss of bone, but it was very minimal. Again, the root resorption, there was no root resorption. And the type of tooth movement, we showed it, the type of tooth movement, whether you used fixed functional or TAD, was almost translational. And the last thing was, the only drawback with the fixed functional was there was more breakage. So that was the only difference between the fixed functional and the TADs. So if I have to conclude or take away the message from this study was, fixed functional are more efficient than TADs for molar protraction considering the time. And the fixed functional and TADs assisted molar protraction resulted in molar translational. And there was no adverse effects noted in our group, in either group. Then I wanted to check whether somebody else has published a similar study because we have done a retrospective study. I wanted to see if somebody has done a clinical trial. And nobody has done a clinical trial, and there are obvious reasons for it, the time period. Then I found another study recently published in Progress in Orthodontics. They used another fixed functional appliance, and they used TADs. But their TADs had an indirect anchorage. So let's look at this study in quick time. And what they did was they used the herbs. And if you could see, they've used the herbs. And they have elastomeric chain both on the buccal and the lingual side to protract the molars. And in the TAD group, they did the indirect anchorage to the canine. And then they used elastomeric chain to protract the molar. And look at the demographics. The demographics were almost similar in both the group. The age was pretty consistent in both the group. If I look at the primary outcome, if you look at the initial space, it was almost similar both in TAD and group, both in herbs and TAD group. In the protraction time was almost similar both in TAD and herbs group. And the rate of protraction was a little bit longer in the herbs group compared to the TAD group. The only difference here is, they had more breakage in the TAD group, in the fixed functional group compared to the TAD group. That was the only difference in their secondary outcomes. And if you look at the conclusion, they concluded that, you can use both the appliances to protract the molars. They encountered some amount of the tipping because they were moving the teeth on 1625 stainless steel arch wire, and when you are moving in 022 slot with a 1625 stainless steel, you have a good amount of play and your molar can tip. So they were encountering some sort of a tipping in their molars, and then they noted that when they were using herbs, there were more emergency visits. So which appliance to use? I would say both the appliances are good. The only difference is if you are using forces, herbs, or any other fixed functional. Our study, the other study from Alabama, both showed that the fixed functional, there would be a little bit more breakage. So once the appliance breaks in, you have to stop for a certain time. Either bracket is broken or plunger is broken. So you have to stop it, again reach the certain arch wires to protract it. So my last thing, this is very interesting to me, and this is my new area of research, which I'm looking into it, class 3. And this has become, when I moved from Connecticut to Nebraska, I see a lot more class 3. Our resident sees a lot more class 3. So in last 2 years, I've expanded my knowledge, and we are trying to do some more class 3 researches. Can class 3 be treated effectively, or it's better not to treat them till the growth is over? Usually the problem with the class 3 is not the treatment. The problem is the relapse after the treatment. Can you control the relapse after the treatment? And that's what my cases, my studies, or my new research is focusing on. So I'll show you one case. this is the case when I was in Connecticut. She came to my faculty practice, and she was a 14-year-old female. And you know, like when any person, or this is my philosophy, comes to me with class 3, I only treat the maxillary arch. I'm not going to touch the mandibular arch. Regardless, I don't extract it till the growth is over. So that's what I did in this patient. Or I will try some dentofacial orthopedics, and I'll show you why we should not do it, actually. So you know, like maxilla was constricted, and I used, in this patient, I used 2 TADs to expand it. And you will see, you know, like in the subsequent slides, you know, like the maxilla started expanding, taking the arch form. And then, you know, like there's a huge midline diastema. At this point, you know, like the midline diastema is increased. And then at this point, I thought, you know, like I've achieved the success, and now I will start aligning the upper arch. And if you look at it from here to here, there's improvement in the facial profile. And this is very common with all the class 3, because as soon as you put an expansion appliance, whether it's tooth-borne, whether it's MARPI, whether it's archwire-based, it takes your A point forward. And as soon as you take your A point forward, it will have more lip support, and the patient will look better. So I started aligning the upper arch, and then I put the Bullard plates, because I wanted to control, and I thought I can control the mandibular growth. And I thought there is a 50% chance. That's what I tell all the parents, that I will try this technique, but it's a coin toss. I might save you a surgery, and we'll decide that once the growth is over. And if I cannot, we can discuss the other treatment options at that point of the time based on the skeletal severity. If the severity is strong enough, I will recommend the surgery. If it's not enough, I might do extraction. So you know, like, but there's a waiting game. So in this patient, you know, like, we finished it very beautifully, and we did follow on the retention. It did not relapse. And this has been published in one of the journals as a case report. And then, you know, like, this is how there was some, exactly the superimposition happened. There was, you know, like, how did we correct it? There was some tipping of the upper incisors, extrusion of the lower incisors, and protraction of the molars to correct the class 3. So you know, like, I wanted to see, is there an evidence regarding my way of treating class 3? And I took it out from Hugo de Klerk, how Hugo de Klerk treats. So I just wanted to see whether, you know, like, is there an evidence that relapse could be prevented in class 3? So I started studying, you know, like, before I do any of my research or before I file any clinical trials, you know, like, I do a thorough study, or my residents do a thorough study, and that's what we were doing it. And then, you know, like, what Hugo de Klerk does is, in all his patients, he has 2 plates in the top and 2 plates in the bottom. And then he will give his elastics, and then, you know, like, he will correct his class 3 like that. So, you know, like, this is a, in this study, he had 21 consecutively treated patients with BAM, and 18 matched control. They were not treated, and they were taken from University of Florence, Italy. 4 mini plates were placed. After 3 weeks of placement, initial force of 150 gram, then increased to 200 gram, and after 3 months, it was increased to 250 gram. And then he obtained the CBCT scans twice, once after the plates were placed, and second, after the treatment was done. And this is exactly, you know, like, he said that the 18 of the 21 patients were prepubertal. They were 8 to 9 years old. And rest 3 were at the stages of 1 to 3, or they were 11 years old. And these were the Ceph parameters he measured. And I'm going to show you some of those measurements. And then he looked at a brief time period. This is the control. And this is the mandibular maxillary length. He said if you give his device, you can lengthen the maxilla by 5.2 millimeters. And this is the McNamara measurement for the mandibular maxillary length. And again, he said that with 2 different parameters, he's showing it that if you give his device, the Bollard plates, you can lengthen the maxilla. And then he said he can control the growth of the mandible. He said if you don't do anything, the mandible was growing, but if you do it, he can prevent the growth of the mandible. So what he said that PAMP protocol, that's what he said, bone anchored maxillary protraction, can effectively increase the maxillary growth. The second thing is he said that he can lead to favorable mandibular growth. And you know, essentially he's saying in few words, he can change your genetic makeup. That's what, as a bone physiologist, as a geneticist, I will take it out. He's trying to say that, hey, whatever genes you have, I can repair it. And then I had a chat with Hugo de Klerk or his collaborators in North Carolina, and I did ask them, hey, what about the follow-up? So he gave me an answer that, in Europe, people are treated and then they move to higher education at other parts of the Europe, so follow-up is tough. And I do agree with that, follow-up is tough. So what I did was, I started looking at more literature because I wanted an answer, can you prevent the relapse? Because my patients, one patient was successful, which I showed you, but there were 5 patients behind that, they were unsuccessful, which I did not show you up, right? I can only show you the success, but I did not show you any unsuccessful case. So I was looking at is there any randomized trial published? So very recently, an Egyptian group, along with Sydney group and Benedict Willems from Germany, they published a clinical trial. And I wanted to see what's happening in their clinical trial. So their clinical trial, they had both the control group, the BAMP group, and the non-BAMP group. And this is their device. And their device, I just somehow love this device, and they had 2 TADs, that's what Benedict does, and they have an expansion appliance, and then they have a molar hook, or the hook, which they will use to protract like this. Here there are 2 TADs, and this is a device or the plates fixed to it. There are 2 TADs here. The good thing with this is, what Benedict or the Egyptian group did was what Eric Liu proposed forward, that you do alternate constriction, expansion, constriction, expansion, constriction, and at the last 9th week, do the expansion and then give the elastics. Because their thinking is that they can do disjunction and maxilla, you can take it forward. Again, they did alternate expansion and contraction. And then they applied 100 gram force through elastic initially, and later 200 gram in the 2nd month. And they recommended that the patient does 24 hours of elastic wear, and they change it every day twice. And this is how one of the cases they showed in their literature or in their article, how the class 3 was corrected. And if you look at the methodology, the treated group and the control group were similar in all the aspects. And I'm going to show you, I put all the same parameters I put for Hugo de Klerk study. Some of them I have reconstructed myself. So, the maxillary length, if you look at it in the treatment, is increased, both through McNamara and through true vertical. And again, the mandibular length, they showed less modification of the mandibular length, and it was not significant. Essentially, what they showed was that you can increase the mandibular length. And the second thing they said is that you can change the mandibular position. And their conclusion was, they call it MAMP. MAMP protocol can effectively increase the maxillary growth. And the MAMP protocol can control the sagittal growth of the mandible, and it provides good vertical control. I was a little bit confused because, my education in Connecticut told me you cannot stop the growth, right? And I was a little bit confused. So, I went to the classic article of Junji Sugawara. Junji Sugawara, this is the most classic article, and Junji Sugawara, Mithani, Dr. Nanda, over the 9 years, they followed the patients, right? They followed it from 7 to 17 years. And I'll show you what they showed us. They had 63 class 3 patients. They gave the chin cup. They gave the chin cup in 7-year-old patients for 62 months, 9-year-old patients for 51 months, 11-year-old patients for 49 months. And this is exactly how their chin cup looked like. And then they had a control. They had 105 control at 7 years, and at various time points they had the control, and then they have showed it how the control growth went. And if you look at it, when you give a chin cup at 7 years, you can control, you can reposition the mandible backwards. But you can reposition the mandible backwards. But what happens when the growth spurt hits? Mandible grows and it becomes similar to control. And this is all long term. Again, look at it. If you give a chin cup at 9-year-old, you can control the mandible a little bit. Then the growth spurt will hit 11 or 12 years. Mandible will grow as normal, very similar to the control. Similarly, same things will happen at 11 years. You will give a chin cup. There would be backward positioning of the mandible. Growth spurt will hit, and it will be very similar to the control. And at the same time, you can look at it, the maxilla is coming down and forward. You cannot control the maxillary growth too. So if you compare it, right, G7 to G17, and in all together if you compare it, there would be, that's what they conclude, there would be 1 to 1.5 millimeter of mandibular length difference if you give chin cup for 60 months versus not giving the chin cup or versus not doing any dentofacial orthopedics. And this is the only article which is longitudinally followed for that long in humans. So this is one of those classic studies, and we have to follow them. So chin cup, seldom altered inherited prognathics class 3. Favorable profile is difficult to obtain by orthopedic therapy. And in long term, everything is offset by growth. So I will leave it up to you. You want to do crazy things, you can do it. Again, it's a coin toss. It might work in one patient. It might not work in another 10 patients. And that's what I did today. I showed you the success. I did not show you any failure. And I would like to thank all my dream team. These are the folks I'm very thankful to. I cannot do it alone. My residents, they help me a lot. And at the same time, I want to say that we just recently started, this is an advertisement. We recently started our fellowship at UNMC. We are taking 2 candidates, one every 6 months. If you know somebody, they can contact me or Dr. Chen, who's our fellowship director. And this is the beautiful place I moved to, and I'm enjoying my last 2 years here, and I do a lot of clinical trials. And if you have any questions, I would be happy to take any questions regarding my talk today. Thank you.
Thank you, Dr. Sumit, for a wonderful presentation. I would really appreciate all the hard work that yourself and your team has put together to present to us these clinical pearls that we can carry. It's very difficult, I understand, to conduct such research ourselves, but you've been doing all the hard work. Thank you for that. And thank you for doing it well on time. We are already running late. And Dr. Sumit has already shared his contact details for anyone who has these questions. So I would now request Dr. Sumit to please come and accept as a token of our appreciation.
Now I request both the chairperson to kindly give away the memento to Dr.
How are you? I haven't seen you.
Good afternoon, ladies and gentlemen. We have an eminent speaker, Dr. Kenji Ojima, who has traveled all the way from Japan to enlighten us with lot of knowledge. Whatever he has gained, he wants to spread it to India now. I would like to keep it very short and simple. Kenji Ojima has done Master in Dental Sciences. He is a professor at University of Torino, Italy. At the same time, he is the president of Japan Academy of Aligner Orthodontics. Not only that, he is an editor of Journal of Aligner Orthodontic Quintessence, director of Smile Innovation Orthodontics. I don't want to talk much about him. His lecture will going to talk about it. So I would request Dr. Ojima to take over the stage.
Thank you. Namaste. So I'm very happy to be here, coming to sharing my experience. Thanks a lot for the kind introduction about me. I'm very respect for the Indian orthodontist because a lot of the speaker coming to here, then sharing our knowledge, right? So could you turn on the sound? This is the including sound, yes? Okay. So yesterday I had a lecture pre-congress course. Thanks a lot, Professor Balaj. I'm very interesting and exciting day yesterday. So I came to here in India 2 years before in Pune. At this time, I'm very wonderful memories. I love masala dosa. I love masala chai. After back to the Japan, I searching Indian restaurant close to my clinic. Then I go to the Indian restaurant, then I order to masala chai and masala dosa. And I love curry also because my dad already 50 years ago passed away. My dad all the time, every Sunday, eat a curry. Me too. Curry is the most my favorite food. So I definitely respect for the Indian peoples and the Indian cultures and the Indian food. So today my topics is the totally change the last 2 years. So many of the doctors thinking about my lecture is the focus on company aligner system. Yes, I do. I do company aligner system since 2006. But now, 2024, what is the future? What is change, innovation, my clinical workflow? I will show you today everything. The next generation aligner orthodontics here in 2024. Before going to my lecture, I want to thank Dhanyawad, all of the attendees and the moderators. I'm very happy to here come again in India. This is my short information. I am adjunct professor University of Torino, orthodontic department, and the former Invisalign faculty and the clinical speakers. I had 10 different cities in India. I had a lecture in Invisalign seminar. Before COVID, I think, we have over 4,000 Invisalign cases, and now we have over 800 new generation aligner orthodontic system. This is my clinic. The 3 different locations focus on aligner orthodontic, center of the Tokyo. And I have a digital laboratory after COVID situation because now we have manufacturing myself. This is the most important part, digital laboratories. And we have education studio. Every day we do online lecture, webinar, YouTube. If you have a chance, please search in my name. Easy to find out my YouTube channel, everything. So my friend Nick is before COVID, is a visit to my clinic. And my friend Ajit also, and my mentor Junji work together a long time. Then if you have a chance, please visit to my office in Tokyo. This is my mentor, Dr. Werner Schupp from Germany. I learned from him a lot of the things. Then totally changed my approach for the aligner orthodontic treatment. Education is most important thing, I think. Please have a look. The many of the doctors, patients thinking about aligner is just only anterior tooth correction. Simple case. But please have a look. Open bite, deep bite, AP correction, molar distalization, and the extraction case want to space closure, we do only aligner orthodontic treatment. Since 2006, we do everything, yes. But my interesting is changing. After graduate university, I started to labial braces, then incognito, started to 2006. My aligner journey is started. Then now, my definitely interesting is shape memory aligner approaches. 2 years before, 2022, I come to here in Pune. That is wonderful memory. At this time, my lecture is this: 100% Invisalign approaches. Then, what is the change? 2 years. I come again here, Bangalore, very nice, beautiful city. What is the different? What is the new approaching for my clinical workflow? I want to share with you my respectable Indian orthodontist colleagues. What is the change? The big change, including shape memory aligners. But today I don't have many time, just only 40 minutes. Then I focus on just only 6 topics, but more including shape memory in-house aligner function. Initially, I want to talk the shape memory aligners. That is amazing. My mentor, Professor Ravi Nanda, he all the time talking about this. That is like a night-eye wires. That is amazing. Doing shape memory aligners, that is more flexible tooth movement, easy to alignment, easy to leveling. That is amazing. I'm very surprised. Many of the doctors asking to me, Kenji, why do you use shape memory aligners? My answer is very simple. Better tooth movement. Better for patient. Then I choose it. Because orthodontists have to know, have to use better appliance for lovely our patient, right? Simple reason. You can see the some form aligner is aligner tooth movement force is become going to down. But the shape memory function is still, that is totally different, right? You can see manufacturing process is more simple. Scanning, simulation, printing directly aligners. No need printing model. That is more good fitting for the tooth. Better tooth movement. You can see 3 times more precisely fitting for the tooth. That is better, right? This is a totally different procedure. Printing procedure is just right size. Then aligner gripping is much better. Then we can do more better tooth movement. You can see this aligner amazing into human body temperature. After 1 minute, 2 minutes later, become original shape. That is amazing. Totally changed. My friend, Professor Ki-Bong Kim lecture article, this is some form aligner is blue color. If tooth movement, 0.3 millimeters, have to need 50.04 Newton. But the shape memory direct printing aligner, same tooth movement, but just only 1.57 Newton. More gently force, more light force. Better for patient. This is one of the reasons. The second reason is this. This is published on the article 2022. Which type of the design is better for tooth movement? You can see very easy. Scallop extend, straight extend. Which tooth is better movement? My job, our job is tooth movement, right? According to this article, which type of the margin is better? Answer is easy. This is a different article, 2022. Which margin is better? The conclusion is very simple. Same as us, 2 millimeter straight extend is better fitting, better control, all kind of the tooth. Okay, next one is this. Block out. The some foam aligner have to need a lot of the block-out. Do you know? Then if you use some foam aligner system, have to need a lot of the block-out. If without block-out, cannot remove. Then have to need a lot of the attachment, right? Most effective area is undercut area. If aligner gripping undercut area, it's better. The some foam aligner is cannot block undercut area, but the shape memory aligner is possible. Why? This is no need too much block-out. This is some foam aligners, but if shape memory aligner, this graphic company material is human body temperature, become original shape, but into the hot water, this aligner material become soft. Then into the mouth, after that, gripping is better. That is amazing. I never heard this material. Using shape memory function, aligner can grip for undercut area of crown. It's most effective of control for the tooth movement. I want to use it. Simple reason. Then, what is next? This is a less attachment. Do you know less attachment? If using shape memory aligner, if using aligner margin is different, if block out is less, gripping the undercut, we can do less attachment. No need too much attachment right now. Too much attachment is already old style, right? You can see our article with Ravi, thanks a lot, Ravi. We published on the article 2023 which type of the attachment is good. They're almost same. Vertical rectangular attachment is good. But if you want to start shape memory aligners, you can reduce attachment. That is totally innovation. Old style, new style, which want to use for your patient. Right now, 2024, we can do more reduced, more comfortable, less etching procedures. If your patient, kids, young generation, your kids, do you want to use etching first? No. Without etching, it's better. My mentor, Dr. Barna Shoup article published on the JAO, according to this article, this is shape memory, this is possible to reduce attachment. Now you can see our team, the many of the case, reduce attachment, aligner margin, 2 millimeter extend straight margin. We cannot use scallop margin anymore right now. This is gripping is better, comfortable, and gently forced without any attachment. You can see this patient into the aligners. Initially, not good fitting, but after 1 minute later, shape memory function become gripping this crown. No need right now chewy. Nowadays, we don't need any aligner chewy, less chewy. Last time, Pune, I have to talk, chewy is most important thing. Attachment is most important thing. But right now, this is old style. Have a look, this one of the patient, clouding, narrow arch, deep bite, midline deviation. I want to correct this patient. You can see using shape memory aligners without any attachment, but alignment, uprighting, leveling, midlines correct, everything do. This is the final situation. Just only shape memory aligners. That is amazing, right? 2 years, totally changed. Still, old style, or super cool Indian orthodontist, you already know what is the future. 2 years before my lecture in Pune, at this time I explained this one. This is a gold attachment. 2 years before my lecture, I using this movie, but now we don't use anymore. This is already old style. Too much attachment, no needed right now. Better for patient, better for clinic. How to use it? How to management, staging? I use these 6 steps. That is most important thing for me. I will show you step by step. Initially, I have to check patient condyle position. If patient condyle is good, started orthodontic treatment. But the patient condyle position is not good, some problem, we use splint therapy first. After splint therapy, function is good, then started to orthodontic treatment. Step number 2 is cephalometric analysis, how to change the mean average to patient. Third step is aesthetic, midline, smile line, center of the incisors, canine position, that is most important thing. And the step number 4 is digital setup, alignment all the tooth, very fast, because using digital software is very easy. Root, crown, bone, face, all data integration, super fast, very simple. Step number 5, I have to check root position into the bone or not. Just only alignment crown. This is a TV game, right? We have to more anatomical driven alignment. We have to check every single tooth, but very fast using software, right? This is a precisely right position. After that, we started to staging procedures. 2 years before, I used company aligner system. At this time, we have to think 2 years treatment planning staging. But right now, in-house system, shape memory aligner is just focused on only 1-2 months. 1 or 2 months, same as braces, same as MBS. Focus on 1 millimeter, focus on 2 millimeters. This is a more predictable tooth movement, right? We do right now 2 years, totally change my approaches. Still 2 years or 2 years more advanced. Only your decision, okay? What is more better orthodontic treatment for the aligners? Now you understood, very simple, right? This is easy. Then I planning every single patient. I will show you one of the case. This is a very simple case. This patient want to alignment anterior teeth position. Take a photo, cephalometrics, then want to alignment. Started to shape memory aligner, in-house system. Scanning, simulation myself. Printing, initially scallop margin. This is more easy to remove, easy to insert. After 1 or 2 months later, scallop margin become straight extent. Initially like this, after 2 months, change the margin. This is a finally totally less attachment procedure for this patient. Nothing, just only aligners, shape memory. Final situation, midline is correct, +1 relationship achieved, and the smile line is good, facial midline, dental midline is correct. Treatment time is just only 4 months. Now we don't need the company aligner order system. We do everything. Achieving the impossible, how to do that? The software is help your approaching. This software is very simple. STL data, cone beam CT data, facial STL data, all data integration, just only 5 minutes. Every data easy to integration. Then I have to check where is facial midline, smile line, root position. Simple, faster, easy. Only crown, only tooth movement simulation is old style right now. Crown, root, bone, face, everything. The joint also integration is clearly. You can easy to understood where is the right position for this patient. I will show you another patient. This patient want to change facial midline and dental midline is deviation. You can see just little bit deviation. 2D data, sometimes just a little bit confused. But the 3D facial STL data is definitely light facial midline area. Easy to understood alignment. On my PC, no needed send to the company right now. We do everything. This is my approaches. And I will show you staging. The staging is different. Evolution number 6, different in thinking about staging. We call if staging or reality staging. What is this if staging? This is a company aligner system. Reality staging is in-house aligner system. You can see this is a class 2 upper molar distalization staging. Second molar, if 100% distalization, then started to first molar distalization. If first molar distalization 100% achieved, then started to premolar distalization. Premolar distalization, if 100% perfect, started to canine retraction. All the time, if, right? 2 years later, nobody knows. Only God, right? Very complex. Every single orthodontist, every single doctor very confused because we have to think 2 years later. But in-house system is very simple. You can see just only 4 aligner is 1 millimeters. Another 4 aligner is 2 millimeters. I just control just only 1 or 2 millimeters, then printing. Give to the patient. Very simple. No need printing so long. This is a totally change my approaching. If staging or reality staging. Right now, we can do more reality staging for the aligners. Still, if staging or not. If started to reality staging, is totally different. Outsourcing aligner is all the time, lot of the aligner give to you. But the in-house just only focus 1 or 2 months. Very, very simple. After that, these 6 innovation, then we can go to clinical case. I will show you how to treat the shape memory aligners, extraction case. What is different? Company aligner system to in-house aligner system. This is one of the patient bimaxillary protrusion, open bite patient. I use NemoCast software, the same as this. All data integration, STL, cone beam CT, facial STL, everything integration. How millimeter retraction is safety, and we have more aesthetic profile, how to get it. Everything on the computer, do myself, analysis myself, not order to the company. This is initially post-extraction. You can see retraction, totally less attachment, totally less class 2 elastic, just only the shape memory aligners. What is different? Company system, in-house aligner system. Different is thick. Attachment, no needed right now. Button cut, elastic, no. It depends. If you want to use, it's okay. Staging is different. Refinement is more faster. Speed is change. Biomechanics, staging, comfortable, totally change. If do shape memory aligner in-house system, more or less attachment, but it depends on your plan. It depends on your design. Have a look. This is the next patient. Bimaxillary protrusion, want to change profile. Okay. Extraction. This is a PC. I select this one. Today, I don't have any time. I have to quick. Very simple. No need a company orders. Please, extraction, this tooth, please put on attachment. No. Do myself. Good. Finish. No stress, faster, focus, better result. Because I am in front of the patient. I know everything. Very difficult to order. Please do like this. Because the designer cannot see my patient, right? I saw my patient. I have to do myself. It's more faster. Very simple. This patient, post-extraction, you can see canine, second premolar, only this area put on the attachment using elastic. But my idea still at this time Invisalign. But this is totally different put on the attachment. Directly bonding procedures. You can see directly bonding, floor abrasion attachment initially, after that scanning. This is much better aligner fitting. I don't use attachment template right now. If started to shape memory in-house aligners, now you don't need attachment template. This is a more faster, predictable tooth movement and good tooth movement. Put on attachment, light curing, polishing, scanning, manufacturing aligners. Simple, fast. Chair time is totally less. Quickly. You can see this is originally orthodontic workflow, right? This is a company aligner style, have to need a scanning first. Sent to the company. We get attachment template into the resin. But the 5th generation aligner is direct bonding, then scanning. Totally different procedures. This is how to attachment. Put on this, polishing, edging, bonding, scanning, then manufacturing aligner, then patient give to you. This patient with attachment, with elastic, then remove the attachment, remove the elastic, finally like this, finish. You can see this patient is only shape memory aligners and 4 teeth attachment and elastic. Next case is initially company aligner, then shift to the shape memory. You can see this patient missing upper right, lower right, second premolars. I want to measure the movement for the molars using some form aligners. You can see measure movement upper and lowers, right? Like this. Just a little bit started to tipping movement. How do you do? You can refinement procedures send to the company, send to the same material, same staging, same approaching? No. Nowadays, you can easy to solution is using in-house shape memory aligners. Aligner curve more easy, different material, and printing anytime. You can see the shift to the material right now, put on the attachment big one, then started to gripping using shape memory aligners, then started to uprighting. You can see shape memory aligner is fitting right now. Aligner margin is straight extend, then started to uprighting. Started uprighting, shape memory like this. This is a finally uprighting. Remove all attachment right now. This is the final situation, right? Next case is a sprint therapy with shape memory aligners. This patient problem is 3. TMD problem, gummy smile, and missing tooth. How we do? This patient initially I use manufacture, manipulate right position, then create a sprint from here using sprint therapy, 3 months. After 3 months, patient problem is disappear, started to align us. But you can see molar area put on bite up because we have to fix condyle position. Phase number 1 is only control premolar canine anterior teeth. At this time, company aligner system, some home aligner have to need lot of the attachment. You can see create a space, premolar canine good for the biting, then remove the molar area sprint, started to phase 2, molar extrusion, just only shape memory aligner with attachment. And this patient have to need intrusion up anterior teeth because the gummy smile. Intrusion like this. This is a final aligner set. Now you can see this is a midline correct, class 1 relationship achieved, and interdisciplinary Dr. Masao Yamazaki, thanks a lot, wonderful job. Then finish. Compared to initial final, that is totally different. Next case is this. Skeletal class 3 patient. How we do? My friend Lamont, my friend Von Moon, and my mentor Labi, he all the time talking about this is a more predictable tooth movement using TAD. MSE, maxillary skeletal expander. This patient, 3 weeks using MSE, then mid-palatal suture expansion. After MSE expansion like this, we started to use aligners. But at this moment, if you still company aligner system, after expansion, you have to waiting 3 weeks because just order, waiting. But if you started to in-house, after expansion, scanning, immediately after, give to the aligners, same day concept. Now we do expansion, scanning, manufacturing aligners. You can see after expansion, scanning, the same day concept, direct printing aligner, give to the patient after lunch. 1 hour later, 1 hour and a half, no problem. Please go to the lunch. After back again, I give to the aligners. Another next one is I give to you next week's or shipping your house. Totally game change. 3 weeks later, started to shape memory aligners. Very simple. Close the space. Here to here. 3 weeks expansion, alignment, finish. Totally change approaching. Another case is adult patient. This patient want to change alignment, but this is very difficult because no discrepancy. I explain to the patient, if you possible extraction is better because cannot too much expansion because bone is very less. Right? Now I have to check. This is if 2 millimeter expansion, already root is out of the bone. This is the same as this. 2 millimeter cannot. Just only 1 millimeter is only possible. Opposite side, 2 millimeter is already root is out of the bone. How we do? We use mid-palatal suture separate using MSE for this patient, like this. After that, we can alignment everything. So thanks a lot, Won Moon and Lamont Montpel. Then we started expansion, same procedures, like this. After that, immediately after, same day concept using shape memory aligners. Started to alignment. Now we do just only premolar to premolars alignment, lower arch going to uprighting without any attachment, right? This is 1 month later, 2 months, 3 months, very light force, easy to gripping, undercut also, then good for the alignment. That is amazing. After 3 weeks expansion, then 7 months later, patient is finished. Just 2 months, 9 months, finish. 1 year retention, still good. That is amazing, right? Next one is benefit system. If you using shape memory aligner, in-house aligners, want to reduce printing aligners, right? If you manufacturing yourself, printing aligner too many, I don't like it. How to reduce printing aligners? If you want to motor control, measure movement, distal movement at this time, benefit system is one of the good approaching. My friend Benedict create a wonderful appliance. Easy to control movement for the distal, easy to control measure movement also. I will show you shape memory with benefit system. If this patient come to my clinic, 54 years female patient, this patient have to need a measure movement because anterior position is good. If retraction not a good face, we have to measure movement. How we do? Only use aligner? Yes, okay, we can do that. But more simply, more faster, and more predictably tooth movement is using TAT combination. We can create a surgical guide, and this is a hybrid benefit system. Go to measure movement. Molar measure movement with aligner is alignment premolar to premolars. This is a totally reduced aligner numbers. Then, after space closing, just control anterior region. Just use shape memory aligners. Simple, right? This is a definitely simple procedures. We use palatal anchorage. That is most effective right now. Finally, like this, you can see simple, faster, predictably tooth movement with benefit system, collaboration, shape memory aligners. Next one is distal movement. These patients want to distal movement. Same procedures using NemoCast softwares, surgical templates, then into the patient mouth, like this. This is a very easy manufacturing, hybrid benefit system. White color area is printing, graphic material. Thanks a lot, graphic company. This is a surgical template into the patient mouth, then into the TAT. Same day, place on the TAT, put on the appliance. Faster, simple, predictable, right? And bonding procedure is more easy because of resin to resin, we can use light curing, okay? After curing procedures, just policing, then started to motor distal movement without patient compliance. Without patient compliance, it's better because the patient some of the time don't use aligner too much. But at this moment, if using benefit system, more comfortable. You and patient. Faster, right? Just only this. After that, started to molar distal movement. Premolar to premolar is aligner zone. Molar area is TAD zone. Just only simple push to the distal. Just only 7 months, you can see the molar is distal. After that, we can do anything. Simple, right? And this is a palatal anchorage. Company aligner system time, I cannot use palatal anchorage. But this is same as Nance holding arch. This concept is better. Good for the anchorage, for the distal movement time. Then, without any elastic, without any attachment right now. You can see this is a palatal anchorage. Started to premolar distalization, just only shape memory aligners. Then, this is the final situation. No need a class elastic right now. 2 years before, I had a lecture in Pune, in India. I have to talk. Please use elastic at this moment. But 2 years later, different. Aligner is evolution, not the same. The history of aligner orthodontic. First generation aligner system started to 1926. Arginate, stone model. 1998 started to second generation. Third generation, 2011. Scanning procedure into orthodontic field. Fourth generation is around 2015. Scan, simulation, manufacturing myself, 3D printer, then some foam aligner, give to the patient. Fifth generation started to 2019. Graphic company get a worldwide patent, direct printing, including shape memory aligners. Scan, simulation, printing, skip the model. That is amazing. Nowadays, what is the next 10 years? My clinic using robotic arm. Robotic arm is automatically printing, manufacturing, direct printing aligners. No need a dental technician right now. My clinic, every day, 70 aligner, shape memory aligner, manufacturing from this robotic arm. Do you imagine? That is a future? No. This is not the future. This is now. 2 years before, I cannot use it. Just only company aligner system. But the time is go by. Different. Evolution. Innovative approach is coming. This robotic arm supporting to your clinic. This is the next 10 years. I started to initially 2nd generation, right now 5th generation. This is not commercial. This is evolution of aligner orthodontic treatment. Do you want to still 3rd generation aligner orthodontic, or the great Indian orthodontists have to use technologies? Then we go next, 5th generation aligner orthodontic treatment. The many of the future is here, but today I don't have many time. Please take photos, right? After that you can see. The many of the future is there. The long time we use some form age, but now you started to shape memory aligner age. 2024, welcome to next generation aligner orthodontic treatment. So yesterday, the guys talking about the wonderful session. I'm very interesting. Please, I open the mind. Welcome, right? Everybody, we are a friend. I want to share my knowledge. Anytime, please question to me. Manufacturing is very simple. Very simple. Using graphene aligner material, this is the only patent, the shape memory function, and simulation software, printer, material. Only this. Simple. Not complex. Right? Initially, just only this one. You can see this number is just only my clinic printing. January 3,000, February 3,000, March 4,000, April 4,600, May 4,000, June 4,000, July almost 5,000. Totally this year, just only my clinic is 37,000 shape memory aligner printing. After 1 minute, my lecture is finished. What is the next? Outsourcing aligner have to need attachment, 68%. But shape memory aligner, this year, just only 3 patients. Manufacturing is very simple. Printing, just only 30 minutes. 30 minutes, you can print 8 aligners in your clinic. Right now, no need send to the another company manufacturing. You can do more delivery faster, more patient-friendly, better tooth movement, more light force without any attachment features, the better for you, better for your patient. You can see this is just only 32 minutes printing. Nowadays, my clinic, 1 day each, over 300 shape memory aligner manufacturing. Very simple procedures. You can ask to the graphic company booth, okay? Most important thing, you can do alcohol wash, 10 seconds. This is the remove all unpolymerized resin. That is the most important thing. Less than 10 seconds, most important, okay? So now we go to my conclusion. You can take photos. This is the procedures, simple. 30 minutes printing, 6 minutes spinners, 10 seconds remove, 20 minutes UV curing, polishing 1 minute, 10 seconds alcohol wash, 1 minute ultrasonic, 1 minute boiling. Give it to your patient. Simple, not complex right now. Which is inefficient or efficient? That is most important thing. Originate impression, digital scanning, some form aligners, direct printing aligners, thinking about 2 years, if staging or reality staging. Give to the aligner, 72 aligners? No, right now, just only 8 aligners. 2 months. After 2 months, come again, I can take a check. If needed, scanning. If no needed, scanning no less. Like this multi-bracket system. I want to introduce wonderful international orthodontic conference next month. UTE is here, so I had a lecture also. If you have a chance, please come to Italian Orthodontic Society. And the next month also, Korean Orthodontics Society as KAO. I had the pre-congress, and if you can, visit to the graphic company tours. And this is my society in Japan, Academy of Aligner Orthodontic. 2 weeks before, we do internationally conference. If you have an interesting, please take a photo of this QR code. You can watching on your PC. This is on demand until this month, okay? If you have a chance, please visit next month our society. It's okay? So now going to the conclusion is this. Very important thing. If you want to continuous education, please take photos. My friend had a lecture in India. He and she very nice experience. If you want to search shape memory aligner, you follow to this wonderful orthodontist. This is the take-home message from with Ravi. Direct printing aligner, no printing model right now. The shape memory aligner, effective tooth movement. Stepwise aligner orthodontic approach is better, simplified. Manufacturing in office, this is a wonderful approach for your practice. No need at many aligner when you use two shape memory aligners, less unfit troubleshooting, and high quality software help your treatment planning. Finally, thanks a lot, my friend Unsop Sim and my co-workers, Sato Dan, Yuriko Kumagai, and this is the final my message. The reducing dental model printing is good for environment. Direct printing aligner technology that is also good for the planet. I hope that in the next 2 years, more doctors will be used early-friendly aligner material. Finally, thanks a lot, my mentor, Professor Ravi, Professor Junji, Werner Schuf, my friend Benedict, and Dr. Masao Yamazaki, and Hitoshi Watanabe, Chisato Dan, Yuriko Kumagai. Thanks a lot. Dhanyawad.
Thank you.
Good evening, ladies and gentlemen, my colleagues and friends. Let me introduce our mentor, Dr. Sadashiva Shetty. He actually specifically instructed me not to give the whole introduction, but I have to tell you something that he was our mentor and an educator for over 39 years. And he has mentored around 49 postgraduate students to achieve the membership of Orthodontics RSCS UK, a respected speaker. He has delivered over 124 guest lectures and led nearly 40 continuing educational programs. And before I hand over the stage to the legendary teacher, our mentor, I am happy to state that we have just honored, we have heard, we are all honored by the news that Sir will be conferred Professor Emeritus by the largest health university of the country, Rajiv Gandhi University of Health Sciences. Over to you, sir. The stage is yours.
Okay. Good evening, my dear colleagues. It is indeed a privilege to be in front of you on this prestigious conference, and I especially thank Dr. Silju Matthew and Dr. Akshay Shetty for having given me this opportunity. Also thank the chairman and co-chairman for giving me a wonderful introduction. We are in a particular stage of history. Orthodontics has been in existence for more than a century and a quarter. And we have seen what are the changes that have happened in these 100 plus years. And what we have learned as teachers, it is my duty to share with you what we have gone through and what you should expect and how you should think what good can be done to the profession as youngsters. Okay. That is a Kannada script saying that Swagata means all are welcome. So evolution is not just a process of change, but a continuous dialogue between past and future. Dr. Albert Einstein said, imagination is more important than knowledge. For knowledge is limited, whereas imagination embraces the entire world, stimulating progress, giving birth to evolution. My dear friends, it all started in the late 1800s when Dr. Norman Kingsley, who was a wonderful orthodontist, designing various types of removable appliances for the unfortunate cleft individuals. Now, this is all started then, at that time, one of the appliances which I am going to show you, which we did in our department, and that is the result we got. Okay, by this time, in late 1800s, all of you must have studied the Wolff's law of transformation of forces. Theories of bone plasticity, they put forth the theory of bone plasticity. Functional stresses, changes in the internal architecture and external form was put forth. Norman Kingsley, in the year 1880, put forth the bite jumping method for the first time with an inclined plane to move the mandible forwards in class 2 cases. He designed an appliance. It consisted of an upper plate with a bite plate, inclined backwards, embracing the lingual surface of the lower incisors. The purpose was not to push the teeth forwards, but to modify the whole articulation itself. That was the beginning of the bite jumping method of treatment. Viggo Anderson in the year 1908 used this modified Kingsley's plate after active multi-banded therapy on his daughter Ying for retention purpose during summer vacation. He was surprised to see the result after the summer break and termed the plate as a biomechanic working retainer. This is an activator of muscles. This appliance was supposed to be an activator of muscles and of blood circulation. The device activates the muscle functioning, and in turn, muscles activate the appliance. During my student days as an MDS student, the only appliance we knew is the activator. Now, after going through the literature, we were confident that growth changes can be brought about with some of these appliances. This is a child, a female child, aged around 11 years, who came to us in the year 1992. We made our first attempt in growth modulation, and she was put on an appliance like this, an upper plate, splint-like appliance with an oblique pull head here, force passing through the center of resonance of maxilla and maxillary dentition. The first phase of treatment was for a period of nearly 15 months. Then we switched over to a rapid maxillary expander because the maxilla was narrower than the mandible, and did the final detailing with a fixed appliance. After the treatment, the patient disappeared. She used to travel nearly 300 kilometers every month for her checkups. And after 24 years, she appears in our department again with her 2 kids, 10 and 12 years of age, for orthodontic treatment purpose. And in that 40 years, and she was 40 years then, and the changes what we brought about has remained almost stable. Nothing has changed. And this is how I'm just showing the transition. This was the time when people were beginning to say that all these are of no use, they won't work, it doesn't remain stable. I'm showing you a case here. Don't think that this is the isolated case I am showing. Many cases are there where we have attained such beautiful results. It was Carl Hoppel, a pathologist, for probably making the first move towards evidence of dentofacial orthopedics. He studied the microscopic changes happening in the condyle and thereby histologically declared the potential of bite jumping appliances. Hoppel and Anderson, in close collaboration, worked in close collaboration to coin the term activator and developed the Norwegian system of functional jaw orthopedics. Their correlation led them to publish a book on functional jaw orthopedics. Thanks to Hoppel for probably making the first move towards an evidence on dentofacial orthopedics. He studied the microscopic changes in the condyle and thereby histologically declared the potential of bite jumping devices. When all these things were happening in and around, we were discouraged not to try these appliances. In spite of that, we used these appliances and we could get such good results. Hoppel and Anderson, in close collaboration to coin the term activator and developed the Norwegian system of, When masters of functional orthopedics designed this appliance, orthodontics was an experience-based profession. Knowledge was acquired through empirism, authority, rationalism, and tenacity. Here I am going to show you another case. All this while happening when people were talking against growth modulation. A child in her early mixed dentition period with a class 2 skeletal pattern, with a severe perioral muscle dysfunction, with a severe lip sucking habit. If she is sucking the lip there, I could hear it. Such was the force of her lip sucking. And we put her on an appliance like this, which could take care of her dysfunction, lip dysfunction. we took care of the perioral muscle dysfunction. And then finally we detailed the occlusion with a fixed appliance. And she became like this. Don't ask me how her skin complexion changed. That I didn't do it, maybe Fair and Lovely did it. So that was the change that happened in so many years. So around 1960, gentlemen, I'm talking about appliances which are mostly removable appliances, which are mostly growth modulation appliances. In the present scenario, we don't have any of these appliances. We don't care about muscle dysfunctions. We don't see those things happening in a patient. In 1960, Frankel, an East German, of course Germany is one now, an East German orthodontist, created an innovative device where the operating zone of the appliance was oral vestibule. He named it the functional regulator. The East German means, I hope all of you know a little bit of history, it was a communist Germany. They didn't have sufficient armamentarium to use sophisticated appliances. At that time, this appliance came into India, and probably, I think if anybody, Trivandrum graduates are there, the Government Dental College, Trivandrum, they were the first to propagate this appliance in India. And this patient was put on an appliance like this. He was also a class 2 division 1 case, and that is post-treatment. The key benefit of functional regulator appliance lies in its dual function. Surgical correction of advancing the mandible to the required intended position, creating an optimal environment for the correction and sustenance of the orofacial deformity, muscle function, orofacial muscle dysfunction. Now we thought little differently in the next phase. This is a child aged, when she came to us, she was around 10 years of age. She had an ankylosis of the right temporomandibular joint, maybe because of a middle ear infection or trauma during early childhood. What happened was, she came to us, to our institution, and she developed an ankylosis of the right temporomandibular joint, and they did what is called as a gap arthroplasty to improve her mouth opening. Gap arthroplasty was done at the age of 6 years, and progressively over the years, the face started showing asymmetry, making the mandible deviate to the right side of the facial midline. So we designed a separate, you may call it a Frankel appliance, but it is not a real Frankel appliance. It was, if you see, observe this picture carefully. On the left side, there are occlusal rests for both the upper and lower posteriors, whereas on the right side, there are no stops. If all of you remember your growth and development chapters, it is the vertical growth that completes last. The left side of the jaw, left side of the oral cavity, the teeth and the alveolus are prevented from erupting vertically, whereas at the same time encouraging the jaw on the teeth and alveolus on the right side to grow normally. So the imbalance created between the right and left side because of improper growth, what we are trying to do is only to balance this. So the first year, the third year, the facial asymmetry gradually improved. Then She had a bidental type of protrusion. We extracted the first premolars and did the final detaining of the occlusion. So 4 years post-treatment, the face looks like this. And that is the occlusion we could get in this patient. Now, when we took a radiograph at this particular juncture, we could see a condyle-like structure in the OPG. Out of curiosity, we didn't have the CT machine at that time, those days. So now, out of curiosity, we asked for a CT picture of the same patient. The altered environment of the functional appliance has created a pseudo joint following the advancement of the mandible. That means the mandible was advanced with the midline coinciding. A rudimentary condyle had developed anterior to the articular eminence. Anterior to the articular eminence. This is the articular eminence, and that is the glenoid fossa. This is the tympanic plate. The condyle has moved anterior to the articular eminence, and a pseudo joint has formed. The rudimentary condyle has displaced anterior to the articular eminence. Now another appliance came into existence, that is called the twin block, as a significant transition from one-piece appliance. All this while you saw one-piece appliance. Now you are seeing a two-piece appliance, and it is called the twin block appliance. Dr. Clark claimed a functional mechanism where similar to natural dentition with inclined planes. The occlusal forces transmitted through the dentition provided a constant proprioceptive stimulus to influence the rate of bone growth. Gentlemen, there is a major thing happened in the year in the 1980s. That is, it was in the month of July 1986. It was month of July in 1986. A change made by the American Association of Orthodontists, triggered diverse admonitions. That means in the month of July, Americans usually do everything in the month of July. Their Independence Day is in the month of July. They land in the moon on the month of July. They do, and most of their presidents' birthdays are in the month of July. So what happened? Such were the comments when AAO official journal added dentofacial orthopedics to its name. Earlier it was called only American Journal of Orthodontics. Now what happened? In the year 1986, you can see that. In January the name of the journal was American Journal of Orthodontics. In July it was American Journal of Orthodontics and Dentofacial Orthopedics. If I am right, Dr. T.M. Graeber was the editor around that time, and he was slowly getting, because during that time, Dr. Frankel from Europe came to America and showed some fabulous cases treated with his Frankel appliance, and he totally fell for it and changed the name of the journal itself as American Journal of Orthodontics into American Journal of Orthodontics and Dentofacial Orthopedics. There was severe criticism for this change. If facial orthopedics stand for influencing facial growth, I wonder whether this addition is justified, referring to our limited ability to change growth. So said Dr. Morris. Another stalwart, another critic, Dr. Lyle Johnson said, something is severely amiss when the specialty concentrates on growing jaws without giving any serious thought to the basic mechanisms involved. Yet, by that time, twin block had already gained popularity on the other side of Atlantic, that is, in Europe. Likewise, when Angle introduced the latest and the best fixed appliance in the year 1928, Charles Nord had initiated an era of removable appliances in the Heidelberg meeting. Europe and America think differently. Differences in European and American thinking are neither new nor is orthodontics an exception. Development of fixed wide jumping appliance for the anti-displacement of the mandible was introduced by Dr. Herbst in the year 1909, but it slowly disappeared and forgotten. We were the first people in India to try out the fixed wide jumping appliance, that is the Herbst appliance, in the year 1988. And this is one of those child for whom we had treated with the Herbst appliance and then did the detailing with the big appliance, not edgewise appliance. And we ended up like this. We were learning photography also during those days, and you can make out from the way we have taken those photographs. By this time, Angle, the great thinker, he said, just beginning to realize how common and varied are vicious habits of lip and tongue, how powerful and persistent they are in causing and maintaining malocclusion, how difficult they are to overcome and hopeless to success of treatment unless these are overcome. Nowadays, we don't care about these dysfunctions, muscle dysfunctions. He had mentioned this, that muscle dysfunctions are to be attended to before you start really any treatment. During the later part of 19th century, orthodontia, that was how it was called, emerged as a specialty solely by the endeavors of Edward H. Angle. Being a qualified prosthodontist, his interests revolved around occlusion, which persuaded him towards orthodontics. Probably, no other man in dentistry did more to foster this branch of science as a specialty than Dr. Angle. Over the years, Angle developed a series of appliances in search for the best. He was the pioneer who first attempted to control movement of the teeth in all three planes of space. These are the various appliances designed by Angle. Angle gave the profession the bracket and Tweed gave the appliance. Tweed's standard edgewise appliance was widely used as an orthodontic appliance system up to the end of 1960s, with, of course, some modifications. Tweed also gave clear guidelines as to the goals of orthodontic treatment, clinical use of cephalometrics, anchorage preparation, orthodontic wire bending for edgewise appliance. Once called by Angle the latest and the best, his appliance is now the oldest and among the least efficient of all edgewise appliances. The fixed badging appliance again made its appearance, along with the regular fixed appliance. Hans Prancher in the year 1977, almost 68 years from the birth of fixed functional appliance, again introduced the Herbst appliance. Herbst appliance was introduced for class 2 treatment, which did not require patient cooperation. The emphasis is on cooperation, patient compliance. He claimed condylar growth stimulation by this method in growing children. Innumerable fixed bite jumping appliances flooded the market, like Jasper Jumper, the Forces, and many other fixed bite jumping appliances flooded the market. And MPA4 was one of them. designed by a Brazilian orthodontist. Here you have a class 2 case treated with mandibular protraction appliance. Treated with mandibular protraction appliance. And we could complete the case in this fashion. I think it is no way inferior to the finish you get with any other appliance. Then came, in 1960, Dr. Begg, an Australian by nationality, born in Adelaide and practiced in Perth, I think, Western Australia, attended the AO meet in 1960 and showed the cases treated with Begg appliance. The Begg appliance consists of 3 stages of treatment. It also put forth the attritional occlusion theory and the theory of differential force into orthodontics. Dr. Kestling and Rock group were stunned by the results, what he showed. And in 1980s, when I was doing my post-graduation, the only appliance that was taught to us and we practiced was the Begg appliance. Even though it's a very nice, beautiful appliances, it could produce wonderful results. People really don't know the biomechanics behind this Begg appliance. So innumerable cases failed because of this. And this is the occlusion we got in this particular patient, and this is what you saw, what you are seeing 14 years later. Now the adult population started becoming aware of their looks. They wanted their teeth to be set right, but at the same time they are embarrassed to wear the any appliance, fixed appliance. So during this time, Dr. Stephen Page introduced the lingual light wire technique. In fact, we tried this appliance in our department also. This was a lingual appliance with Begg brackets, And that is the result we got at the end of the treatment. Then came the genius, father of scientific biomechanics. He said, don't believe blindly in experience, but believe in theory and think creatively. Think creatively. Later, before that, any appliance for that matter, whether it's Tweed appliance, Begg appliance, Zeraback appliance, whatever it is, the amount of biomechanics in how it worked, nobody knew. Simply put on bracket, simply put on wire, tooth moved, and if it doesn't move properly, you do something. If it went wrong, again you do something, it went wrong. That was the way it was being practiced. We must thank Dr. Burstone for his leadership in bringing this branch of the orthodontics into vogue. Now I'll show you. Somebody said, one wise man said, orthodontists treat patients' malocclusion for 20 months and treat the malocclusion created by them for another 30 months. That means you didn't know, rather you don't know how the appliance worked. So here is a patient wherein you can see that the canine is distally inclined. And she underwent all four extraction. We put a cross tube. The horizontal tube went into the main archway, and the vertical tube received the uprighting spring made out of 1725 TMA wire. So into this free arm of the uprighting spring, we had an open coil, night-eye open coil spring there. And when we pushed the wire up, the free arm up and engaged into the impacted canine bracket, compressing the coil spring. There are two things happening now. One is the coil spring is exerting a distalizing force, and that force being far away from the center of resistance of this tooth, it created a clockwise moment. It created a clockwise moment. And the upright spring, which was pushed up and engaged into the canine bracket, is trying to move the root of the canine distally. So that is why it is creating an anti-clockwise moment. So both the moments are cancelled out, and the canine moved distally. Now, at the end of the treatment, patient looked like this. But of course, you may be wondering, what is this? The patient showed gingival recession in the canine as well as in the premolar, because the bone itself was very less in those areas. And then, with the help of our periodontist, they took a palatal graft and repaired that recession. Innumerable edgewise appliance modifications came into existence. Orthodontists were trying to build treatment into the appliance, and so many appliances came. Jerabax, he was the first to introduce tip and torque into the brackets and called it building treatment into the appliance. Then in 1971, Andrews straight wire appliance came. That was the first generation appliance. In 1979, Roth's increased tip and torque appliance came. That was the second generation appliance. Then came Vic Alexander's appliance, so on. Now I'll show you a case, severe bidental protrusion with severe crowding. These are the cases which required maximum anchorage control, so the headgear was a necessity. Then people didn't want extractions to be done. So orthodontists came out with the idea of distalizing the dentition. Innumerable distalizing appliances came, like Jones jig, K-loop, Pendex, whatever it is. The idea was non-extraction line of treatment. Here you see a Dr. Kalra's K-loop, molar distalization. Gain the space and align the buccally blocked out canines. And this is how it ended up. This was taken many years later. And finally, the appliance which came into picture was MBT technique. Presently, the most widely used technique, most widely practiced appliance system is MBT. The prescription is MBT. You may say Damon, this thing, that thing, but the prescription is MBT appliance system. So that was called as the third generation PA because of its versatility, because of its better anchorage control, because of easy leveling and aligning, space closure methods, and less of wire bending, and finishing was within the orthodontist control. Here, a child in his early permanent dentition. Sorry. If you see, observe carefully, that lateral incisor was behind. With the purpose I am showing this, the lateral incisor was behind the central incisor. And after aligning, the root of this lateral incisor is palatally placed. Naturally, there are many ways of handling it. People say invert the bracket, you give torque in the wire. But what is done here is a reciprocal torquing auxiliary, wherein the central incisor roots are palatally torqued and reciprocally the lateral incisor roots are labially torqued. And that's how he ended. The first, nowadays, and as I told you, Adult patients, more and more adult patients were seeking orthodontic treatment. Adults are impatient. They want the treatment to be done fast. So the surgical line of treatment came into existence. So even though the first leaf-out-one surgery was done in the year 1849, it didn't become popular because of the risks involved, like hemorrhage and infection. People were not practicing this particular method of treatment, and different variations of surgical treatment like distraction, osteogenesis, surgically uncovering impacted teeth, corticotomy, precision, adjunct facial procedures like rhinoplasty and genioplasty came into existence. My dear friends, I am talking about legacy. Remember that. I am not trying to show something different. All four extraction, distraction with mandibular advancement. Here you see a class 2 case, a compensated class 2, skeletal class 2, with severe crowding in the lower anteriors. We decompose the occlusion by extracting the premolars, upper 4 and lower 5s, and put him on a distractor, performed a genioplasty, bucket handle genioplasty. I don't know whether you know it or not, a bucket handle genioplasty, and he changed like this. 11 years later, post-treatment, the guy looks like this. I'm showing you long-term cases because there is a comment made about orthodontics by other branches of dentistry, specialists in dentistry, saying that anything what these orthodontists do, it relapses. So I'm showing you such cases because even some of us didn't believe that the cases can be held down for such a long time. Now, the next case. A class 2 due 2 type of case with a flat mandibular plane, a deep bite, which are the most difficult cases to handle. Aligning and all is fine, but the vertical correction becomes very, very difficult. So we did a non-extraction surgical decompensation, then advanced the mandible, and 17 years later, he looked like this. He was one of our BDS student. I think some of you may be knowing him, who is working in Ambedkar Dental College, correct? He is one of our students. He did prosthodontics. Ambedkar, yeah. And do you think he has got resemblance to somebody? Can anybody guess? Doesn't he look like Abhinandan? Do you know who is Abhinandan? Who participated in the air strike, in the surgical strike? He is from Tamil Nadu actually. He took the MiG and it crashed. Doesn't he look like him? No, just to wake you up, I said this. Okay, management of pre-maxillary surgical complications. It is very nice to see and take pride in saying that I treated this case beautifully, I did that, I did this. But normally we don't show cases which have failed. A 18-year-old female patient comes to with a skeletal class 2 with a not compensated dentition, but a mildly compensated dentition. Her dad, a truck driver, wanted the treatment to be done fast, and so we tried a method of first retracting the lower incisors without touching the upper, and then subjected her to a pre-maxillary setbacks, a surgical pre-maxillary setback. What happened? During the surgery, the palatal mucosa was torn. The palatal mucosa was torn. You know, the palatal mucosa is the major, carries the major blood vessels like greater palatine artery and incisor artery, and because of which the premaxilla underwent avascular necrosis. And the whole of the premaxilla on one side was necrosed, the palate was necrosed, which led to a oronasal communication. With such complications, see gentlemen, that patient still able to smile so nicely, and that is the beauty of our Indian patients. Irrespective of what damage you do to them, if we had to do the same thing in Europe or US, they would have taken for $1 million compensation. What happened? See this? Without any expression of sorrow in her face, she smiles. What happened finally? They tried all methods, hyperbaric oxygen, splinting, all sorts of things they tried, our surgeons tried, but it didn't work. Finally, the patient was left with a huge defect like this, incisor missing, there was a palatal perforation, and she was put on a removable appliance, a removable denture like that. So finally, the surgeon decided to put a iliac crystal graft, augmented the ridge, and then our prosthodontist restored the missing teeth. Normally, the orthodontist or the surgeon, they try to shy away from taking the responsibility. But you should be bold enough to say that, yes, I did it, I'll restore it. And this is how our occlusion looked at the end of the treatment, with the prosthesis in place. So another case. The place where I come from is a rural Karnataka. There are lots of poor patients who come to us seeking treatment. Especially this female child is a daily wage worker. Working in the hot sun, she gets tanned, her skin gets tanned like that. We decided to do again a premaxillary setback, but it was a bi-jaw surgery, lower subapical osteotomy and intrusion, alignment, and she became like this. I hope you liked it. Now we have an asymmetrical face. We took a CT and did a stereolithographic model out of starch, and we used this model to do the mock surgery, the model surgery. And the surgery was performed. First surgery was the differential impaction of the left side of the maxilla by about 6 millimeters to correct the occlusal cant. The second surgery was to restore the lower border of the mandible because it was too much corticated. Okay. All this while, I showed you initially the functional appliances, the removable appliances. Then came the fixed appliances, various modifications of fixed appliances, the surgical cases, and finally, once again, in the year 1997, the adult patients didn't like to wear the appliances. They didn't like to show the braces. They didn't like to show the rings. So Dr. Damon came out with an appliance called self-ligating appliance. Mind you, my dear friends, self-ligating appliance is nothing new. It was invented first in the year 1935 itself. It was there since 1935. You don't think that it is something new has happened. The first self-regulating appliance was developed by Dr. Jacob Stolzberg in 1935. The advances in metallurgical science and understanding the concepts with application made us devise better appliances. So this is one of the cases treated with the Damon appliance. And of course, lastly, the plastic appliances. The plastic era of orthodontics, that is the 21st century, a removable appliance in the current focus Invisalign system, 1997, by two postgraduate students of the Stanford University. In fact, the idea was even older than that. Dr. Kessling in the year 1945 first introduced what is called as a positioner. Why he made this appliance positioner with the latex. Subsequent to the active treatment with the big appliance, he gave that positioners. And of course, this appliance is also used as retainers for patients who don't like to show a wire in their retainer. So, remember, mind you, in the year 2003 itself, we had tried this particular, of course, it's a very simple case. We had tried this appliance, did a Kessling setup, sequential aligners, and corrected a lower anterior crowding and the anterior crossbite. Now the latest is Brava. I think one lecture is there on Brava today, I don't know, tomorrow I think. Invented by one Dr. Mehdi Paker, orthodontist, physicist, and Bryce Company founder, Texas, USA. He is basically an Iranian. So, coming to a conclusion, my dear friends, Walter, more than a century ago, said, we are faced with a peculiar phenomenon. About every 30 years, the prevailing technique or concept or both may change to the reverse. He said it then. It appears that the profession sits on a big turntable, passing through the same phase every 30 years, and that the Americans and Europeans sit on the opposite side. I don't know where we sit. As Indians, I am not aware. So, the Kala Chakra Mandala is a revered symbol representing the concept of time and cyclical nature of the universe. Dear friends, everything keeps coming back, keeps on. You must have heard, you must have seen the TV serial on Mahabharata. The initial picture is one wheel keeps on turning. That means everything keeps coming back. So, my take-home message to you is, it is crucial to approach any method or product with a discerning eye, rather than simply being swayed by marketing tactics. Simply being swayed by marketing tactics. Making informed decisions will ensure that you choose the solution that genuinely meets your needs and stand the test of time. Thank you very much.